supported this project: GSK, Hallmark Foundation, MSD, Pfizer and Sanofi. I'd like to also thank our speakers who have come from across the globe to join us today, and thank you again to all of those joining us virtually. We'll be hearing from a variety of speakers today, and then at the end of our speakers' sessions, we'll open to the floor to answer some questions. For those joining us virtually, at the bottom of your screen, there's a Q&A feature where you can add your question for the keynotes. You're also welcome to engage with us online via X or Twitter. You can use the hashtag PreventionIndex or tag us at ILC UK. But first off, I'd like to introduce Aaron Himawan, the ILC's Senior Health Policy and Research Manager, to present the key findings of the index. Welcome, Aaron.
Good afternoon, everyone. I'd like to start by quickly thanking all of our speakers here today. We really have a fantastic panel, and I'm really looking forward to hearing what you all have to say. And I'd also like to thank everyone in the room for coming and joining us today. I'm really delighted to be presenting these findings, which have taken us about a year of hard work to pull together, and hopefully they will be useful for the work that you're doing and in your areas. So, a bit of a recap, because I know some of you are joining us for the first time. Our Healthy Aging and Prevention Index, which we launched last year, is an online tool that ranks 153 countries on 6 healthy aging metrics. You can see the metrics in front of you. We look at health metrics like lifespan and health span. We look at work. We look at income. We look at environmental performance, and we look at happiness. Since last year, we made some changes to the index. We've included more countries. So we had 121 last year. We've now included 153. And most importantly, we can now track progress over time. The first index captured what was going on in 2019. Now we can look at what's happening in 2022. So without further ado, I'd like to present the top 50 countries on the index. I would have loved to have fit all 153 on one slide, but that would have been a little bit too difficult. You can see there are some countries that hold same ranked positions on here, and that's absolutely intentional. But some of the key findings that we've seen over the 2019 and 2022 period is that Iceland now replaces Switzerland as the top ranked country. More than a third of countries in the top 20 are from the EU. And all 25 out of 27 EU countries are ranked in the top 50. Romania is ranked 54th and Bulgaria 71 on our index. Generally, we see less movement in the top 20 countries. We see movement up and down about 2.1 spaces. The bottom 20, we see a lot more movement, about 4.9 on average movement up or down on our index. So what's been happening since 2019? We're living less. Our life expectancy has decreased. We're living 7 fewer months in good health. Our healthy life expectancy has also decreased. And we're less environmentally sustainable. And this is particularly or primarily due to deteriorating air quality and rapidly rising greenhouse gases. So not exactly what we would have hoped to have seen this year. And not only has lifespan and health span decreased, we've also seen a widening of inequalities, a widening of 1 year compared to 2019 for both the lifespan and health span metric. Again, this is a worrying trend for us. So when it comes to happiness, we've seen that actually happiness levels have remained relatively unchanged. We worked the same number of years as we did in 2019, and we're slightly richer. However, income inequalities have widened between the top and bottom 25% of countries on our index. And we've actually seen those at the top improving in income and those at the bottom declining in income. So this trend is actually particularly worrying when it comes to widening of inequalities. So which countries have been the biggest movers? And one key message to take away from this is we've actually seen quite a lot of variety in the various countries that have seen the biggest movement on overall and also on the specific individual metrics. So Botswana has moved up the most on our index. We see that Nepal has seen the biggest improvement in lifespan, and Bangladesh the biggest improvement in health span. Serbia has seen the biggest improvement in work span, and Ireland the biggest in income. India has seen the biggest improvement in happiness, and Afghanistan the biggest improvement in environmental performance. So quite a lot of diversity here in the countries, which is encouraging to see. In addition to ranking specific individual countries, we also rank political and economic blocs. And like with the countries, this year we've included more political blocs, so like the Commonwealth and BRICS. And the key takeaways from this is we've seen relatively little movement between 2019 and 2022. You can see the last column in white tells you whether this political group bloc has moved, and the majority of them haven't. Scandinavian Nordic cooperation still ranks at the top, and the Commonwealth ranks at the bottom. EU has a particularly low work span, and this has remained relatively unchanged since 2019. So one of the things that we want to do with this index is really pull together a story that tells us what it is that is driving healthy aging and what it is that countries at the top of the index are doing that other countries can also follow suit. So I wanted to share a few of our initial analysis and findings with you today. And the first one is looking at spend on healthcare. And what we generally see is that countries at the top of the index spend more on healthcare. And what we've seen over time, really, between 2000 and 2020, is increases in spending over time across all countries. But those in the top 50 countries have seen the largest increase of 2.5% increase in health spending. Those ranked 51 to 100 see 1.3% increase in health spending, and those ranked 101 to 153 see 1.2% increase in health spending over this time. In 2009, we see health spending leveling out. This is a result of the financial crisis, and then we see a spike, of course, in 2020 because of the COVID pandemic. What we've also seen is lifespan has actually shrunk. When we look at a larger proportion of time between 2020 and 2000 and 2020, we actually see increases in lifespan, and we see inequalities have shrunk. So over this time period, there's been a 5-year increase in lifespan from 66 to 71. And a shrinkage of lifespan between the top and bottom countries. The biggest increases in lifespan have actually taken place between 2000 and 2010. We've seen 3.4 years increase in lifespan, and it sort of leveled out since then. So that is somewhat of a worrying trend, but overall, when we look at these last 2 decades, we are moving in the right direction. So we know that vaccination is one of the most cost-effective and effective tools that we have when it comes to preventative health and safeguarding population health and supporting healthy aging. So we wanted to take a sort of closer look at what adult flu vaccination uptake looks like and across the OECD. So what we generally see, and this is looking at 2021, 2022 figures, is that just over 1 in 2 adults are vaccinated. Take-up is highest in non-EU countries, averaging at about 64%. That's followed by Western European countries at 60%, and then lastly, Eastern European countries at 20%. Countries with the highest flu vaccination uptake is the UK at 81%, South Korea at 80%, and Ireland at 75%. Those with the lowest include Turkey at 6%, Latvia at 8.1%, and Poland at 10%. Huge variation. So this very clearly demonstrates that there's a lot more that we need to do to ensure access to vaccines across the globe. We also took a look at HPV. Of the 153 countries on our index, 118 have introduced the HPV vaccine, 35 have not. Higher ranked countries, so those ranked in the top 10, saw an average a year of introduction in 2009. So this includes countries like Switzerland, Sweden, and Australia. However, when we look at countries ranked in the bottom 60, the average year of introduction was in 2019. Again, huge differences. Majority of countries which have yet to introduce introduced the vaccination are from low and middle income countries, and this includes countries like China and India with big populations, of course. Cervical cancer remains the most common female cancer. However, it's almost completely preventable. 90% of that burden is in low and middle income countries, again demonstrating the real need for access to this vaccine across the globe. And then finally, we took a look at prevalence of tobacco use. And what we've seen is generally it is declining over the 2000-2020 period. We've seen more rapid declines in high and low ranked countries than in medium ranked countries. However, since in 2018, the rate of decline has flattened at around 20%, regardless of rank. And again, that's a slightly worrying trend that we see. So I'm going to leave my presentation here, and just a couple final thoughts, and I hope that we get to continue this conversation during the networking, Q&A and networking. But the overall takeaway key message here is that we're generally worse off than we were in 2019, and inequalities seem to underscore everything that's happening and that we've seen in the last 2 years. If we want countries to fully adapt to longevity, we absolutely need to tackle inequalities and improve health outcomes. Thank you very much.
Thank you, Aaron. And from having worked with Aaron for the past year on this project, I can tell you what she presented today is literally just the tip of the iceberg. There is so much more data and so much more that you can take away from the index. And hopefully you will all be able to take some more away. I'd next like to introduce our first keynote speaker, Dr. Natasha Azzopardi-Muscat, the Director of Country Health Policies and Systems Divisions for the World Health Organization. Thank you.
Thank you, and it's a pleasure for me to be able to represent WHO Regional Office for Europe over here today. The European region is the fastest aging region across the globe, and of course we have been paying a lot of attention to this phenomenon, which we wish to frame in a positive way, because of course this is indeed the result of a number of successful policies that countries in the European region have been employing over decades, and therefore it is no surprise that, as we saw in the index, a number of European countries actually do rather well. I would, however, like to remind everyone that when we talk about the WHO European region, we are talking about 53 countries, not just the EU countries. And in fact, there is work to be done across all the region, but also we are working very closely, for example, with a number of countries in Central Asia who are trying to prepare themselves for the demographic transition. So a few key messages from my end. Firstly, when we talk about this demographic transition, I think one of the issues that we are working towards is ensuring that the additional years of life are spent in good health. It is not enough just to prolong lifespan on its own. And of course, several countries in our region now have many people who are living over 100 years. And we often sometimes interview some of these individuals and ask them. And it's very clear, it always comes back to the combination of the founding principles of WHO's constitution, which is the physical, the mental, and the social well-being. And we need to really also be able to take this step back and ensure that we are looking at the whole. Because sometimes, and as medical professionals, we can be the ones who are most guilty of this. We focus very much on the physical health. We focus very much now on the biological determinants of health. And we forget that actually you need to look at health as a whole. And one of the things that we would like to talk about is that we want to turn the narrative around aging societies into a positive narrative. But for this to happen, we need to change some things. And we need to look through the lens of what we are doing and what we are doing for our populations to age more healthy. And this starts actually from the early years of life. And when we look at the early years of life, there we are concerned. We are concerned not only because we aren't making the progress that we would like to make when it comes, for example, to reductions in childhood mortality, but more worryingly, for example, one of the surveys that we run across the region, the Health Behavior in School Children survey, which covers around 44 countries, uncovers several worrying trends in 11 to 15-year-olds, not least childhood obesity, lack of physical activity, and serious problems with mental health, with anxiety and depression, particularly in our adolescent girls. And for this purpose, we are working now to renew our child and adolescent health strategy, because it is very clear that children and adolescents are not as healthy as they should be. They are living in a very challenging world and environment, and if the health of our children and adolescents wanes, then we cannot really talk about healthy aging. Indeed, a number of countries are also talking about increasing health problems in the working age population, and the phenomenon of many working age adults not being able to work because of some kind of disabilities, again, often very much linked to chronic illness and mental health conditions. But coming to my second point, this is not some kind of even distribution. What underlies and drives the overall numbers and figures is persistent inequalities and growing inequalities. So as soon as you start to unpack what is behind stagnating life expectancy, as soon as you start to unpack even the results of the Health Behavior in School Children survey, what you find is that these are driven by inequities. And therefore, we need to be mindful that if we want to work towards healthy aging, if we really want to increase the health span, the years of life spent in good health, we need to work on those population groups that are being left behind, that are more at risk, that are falling behind. And in this sense, I think we are also mindful of our work on equity. And through our Venice office, which is the office that focuses on investment for health development, we are working very closely with some unlikely actors, such as, for example, institutions of finance and central banks, where we are trying to work towards a shift to enable countries to move towards well-being economies. So, of course, it's not surprising to me at all that you have Iceland at the top of the list. Iceland is one of our champion countries. Indeed, the former Prime Minister Katrín, is one of our champions for health in the well-being economy. Because when we pay attention to economies that are really working to put at their heart the health and well-being of people through life, starting with children and young people, focusing on women, focusing on those people of working age, people from minorities who are often just falling off, that is when the average starts to move. And in the same vein, it does not surprise me that the Nordic cooperation is doing very well, because we see this also in Finland and in Sweden and our other Nordic countries. But is this something that only the Nordic countries can aspire to achieve? And this is where we want to turn the narrative, and we want to say, no, this is not something that only the Nordic countries can aspire to achieve. And indeed, we are working, for example, very closely with Moldova, with Kyrgyzstan, that are putting equity on the agenda and that are interested to see and to examine how they can reframe their economies and find their own model in order to shift towards well-being. Third, we must prepare our societies and our care systems, and I mindfully use the term care systems because we still too often try to make this artificial divide between healthcare, social care, long-term care, primary care, mental health, rehabilitation, palliative care. At the end of the day, what we want to develop are care systems that are fit for purpose to deal with aging and aged populations. And over here, there is much work to be done. And at our Tallinn 15th anniversary conference last December, we spoke about the need to transform health systems. If anything, just the very basic bottom line denominator is that we have a shortage of health and care workers linked to the demographic transition, very marked in the European region. And when I talk about the shortage of healthcare workers in the European region, let me just take a step back and spell out that never, ever have we had so many doctors and nurses in the European region. So the shortage is the gap between the supply and the need and the demand, which is a success story in itself, which is also because of the potential that medicine and science is offering, not least in areas such as cancer care. But of course, within the current models of health systems that we operate today, it's unsustainable, even purely without looking at finance, just from a workforce perspective. And of course, secondly, we can't ignore the digital revolution, AI, and we need to find ways, and there are ways in which we can use and enhance technology to ensure that it is there for our aging and more aged societies. And originally I was told that the Italian minister perhaps might make an appearance, but I'm not sure that he is still going to be here. But Italy, as the chair of the G7 presidency, have put precisely this topic as a priority topic. Healthy aging, and how can we exploit the innovations that are offered in order to transform our societies and our care systems. And then finally, of course, it's also about how we perceive the environments, the working environment, the living environment. How can we make them more age-friendly? How can we build better intergenerational solidarity? How can we change the narratives such that we can make our older persons in society the assets that they can truly be? There is a huge untapped potential if we are willing to remove our blinkers and tap into it, and if we work hard to invest to make sure that our older persons remain healthy for as long as possible. And we need to engage them too. I think we heard a lot this morning also at the World Health Assembly during plenary about delegations engaging, for example, youth delegates. But we also need to be able to engage older persons beyond their activities in the labor market, where sometimes then their voice becomes less visible. And we need to make sure that the care systems that we are designing are fit for purpose for them, shaped by them, and that they are playing an active part also in shaping their communities. And in this sense, the resolution that we have on the agenda at the World Health Assembly around social participation is not only about social participation for young people, but it's also about social participation for older persons. In closing, I would like to say that we are hoping to take forward, as WHO Euro, in the coming year, a framework for action on healthy aging, but that really brings together the renewal of the child and adolescent health strategy and the transformation of our care systems, particularly our long-term care systems, to make sure that they are fit for purpose for an aging society. Thank you very much for giving me the opportunity to share a few thoughts with you.
Thank you so much. And I think your comments there about addressing inequalities is absolutely vital, because when we're talking about improving healthy ageing, we want to make sure it's not just the wealthy well, but it's everyone. Next up, I'd like to invite Dr. Hans Groth, Chairman of the Board at the World Demographic Ageing Forum, to give his keynote presentation.
Good afternoon, everybody, and thank you for inviting me. And it is my pleasure to talk or give a few comments on the topic, why is this indicator so important, and at the end of the day it's a question of closing the gap of something which is really very important, our lifespan. And if we go across the world, we have ongoing dynamics across the globe, and one of the most important dynamics among many others are the growing numbers of elderly people. And we do these analyses usually in age groups, and we look at the age group from 65 to 75. These are the groups and age groups which potentially have the chance for a good life, for a socially and economically ongoing good life. And what you can see here, for the next 20 years you will have growth of the age group 65 to 75 everywhere across the globe. However, with changing or differing dynamics, and then after 2050, the first continent will start where these groups will shrink, which is our continent. On the other hand, the growth of the elderlies on the rest of the world, particularly in Africa, will continue to grow significantly. This is the one part of the coin. The other part of the coin is those people 80 plus, and according to our definitions, these are the ones who increasingly need support and care. And this is very resource intensive, and we have to prepare for this because services have to be delivered and products have to be available, and in addition it has to be financed. And what you see here across the world in this century, the numbers who are needing care is continuously with different dynamics growing. And based on this, these ramifications, the challenge or the question, how do we perform in terms of life expectancy, and even more important, how do we perform in terms of healthy life expectancy, is a critical question, a critical challenge to make longevity a success in the 21st century. I already mentioned to you, aging is not uniform. Aging is diversity. And we have developed 7 classes, or 6 groups of aging spectrums. And you have, on one hand, you have the group of the most aged ones, and guess it is, it's Japan. This is the place where we can learn from. Then we have quite a new group, because 5 years ago we wouldn't have spoken about this, the group of very fast agers, where it happens rapidly. This is China. And then we have the huge group of the early ages. Basically, this is Europe, and I just will show you 3 examples here. It's France, Switzerland, and Germany, but there are as well many others. And then you have the group of those countries where aging is about to come, some type of close followers, which in this case, according to our definition, the UK and the special case of the US. And then, if you have a perspective of the entire world, you have the huge group of coming agers, and the leading group is India. And then you have a huge group of other countries, mostly Africa, where officially, according to the figures, aging is, as of today, not the priority, but it will become an issue. Now, I shared with you the classification, and I tried to convince you we have an ongoing increase of 65 plus groups everywhere in the world, but this is only longevity. But what about healthy aging? What are the differences? How does behave healthy longevity in a world of living longer? This is the critical question to make it a success and to make it affordable and to make it possible for everybody. So the goal is the gap has to be closed. And I give you just 3 examples. It's clear I have to start with the most aged society is Japan. And what you see here is that at the age of 60, the Japanese people, for men and women, is slightly different, but on average, we are talking about 20, 25 years and more of healthy living. But on the other side, if you see the years we live in disability, the years where we have some type of sickness or disease, is growing absolutely as well. So, and this indicates to you a challenge that the years, for example, for women increases more than for men in terms of years in disability. And this is the case of Japan. A little bit similar in principle is the case of Switzerland, where we hear a country which performs very well in the index. But again, you have the challenge that the Swiss people live today at least 20 years at the age of 60 in good health, but on the other hand, as well, the numbers where they live with any type of disabilities is increasing as well. And why do I mention this? This is resource intensive in terms of services and budget. And the question is, how can we afford in the long run to live always longer and longer, but have no clue how to finance it? Because the years in disability in some countries even increase more than the years overall. And the last example I would like to give you is the UK. Again, you have quite a long period where you live with disability, but the years you live in healthy longevity are not as long as in other countries who invest more in health. And what is the challenge now? The challenge is, and therefore the index is quite helpful, our mission is we have to find ways to close the gap. And which is the gap? We have an ongoing gap that 20% of our life is in disability. And the trend at the moment is not shrinking. The trend is that we live longer in health, but we live as well longer, absolutely, in disability. So to make it a success, we must find ways to close the gap. And more than 20% gap is still a gap. It's not just a figure. It's a real gap, and it's tangible, and we can perceive it, but we have to find it as well. And we have the differentiations between longevity and healthy longevity. And in aging societies, in longer living societies, what are the diseases which cause the gap, which create the gap? And again, health is not uniform across the world, and I would like to give you as well 3 examples of different countries. What are the limiting diseases which create the gap causes? And I start with Japan, and I don't have to convince you, and just look at the red arrows. In many diseases, we have improved significantly due to advancements in medical services, etc. But the health gap in Japan is increasingly driven by dementia diseases, which is indicated here with a red arrow. It's quite different in the US. If you look at the figures, the health gap is driven by as well other diseases increasingly, and one is diabetes mellitus, and the other one is, you might be surprised, chronic kidney diseases. And the reason why I mention this, treatment of kidney disease, and it will end up in dialysis, it's extremely expensive. So this gap costs a lot. And the last example, to give you an example from Africa, again, the diseases who create the gap here are again quite different, and on average they are more or less driven in this country as well as in many other African countries by infectious diseases and not non-communicable diseases like in the Western countries. So to summarize, the diseases who create and cause the gap are different, and this will as well cause different policies and guidelines. And let me come to the last question, or my last comment. What could be done, giving you these data about an ongoing gap and an ongoing diverse gap across the world? And what we think from the World Demographic and Aging Forum, that the index is a very important tool to help us to guide policy makers and those who provide the resources and those who design the healthcare systems of the future. And why it is so important or so supportive, this gap, this indicator, because it unites, it combines various elements which create our lives, which create our healthy lives. And these are, that's why we are, it's health, but as well as other societal metrics, including as well the work span. And with this, you have today now the latest update of this indicator as a tool, as a starting point to design your individual policies and recommendations for the countries. Thank you very much, and thanks for listening.
Thank you very much. I'd like to now introduce our next speaker, Marta Lomanzi, the Executive Manager of World Federation of Public Health Associations, to give her keynote.
Thank you very much for the invitation. It's my pleasure to be here and to speak about public health approaches. I represent an organization that bringing forward the voice of over 5 million public health professionals worldwide that need to face every day the challenges that we have just seen in the index. So we need now to go to the next step and define how to concretely tackle these problems and find solutions to increase the health of our population, especially when we consider that the population in the world is aging. And I have decided to focus on one specific example today with this older adult immunization, which is one of the main focus of our organization as one of the most effective ways to prevent the disease. I like very much when Natasha spoke about care system, but I would like to add that we need to have a preventive and care system, because in the current context where we cannot cope with the demand, we need to limit the demand. So to find ways to keep people healthy before making them in the need of looking for care. So today with you, I would like to discuss three main areas, three main key points. The first one is that the factors influencing healthy aging are very different and varies a lot according to countries, as the other speaker have already somehow cited. The second point is that the adult population is highly complex and diverse, and the older adult population is even more complex. If you think about the older adult group, we have people that are still very active, working, taking care of grandchildren, traveling, being businessmen, business ladies, but we have also people that have comorbidities that cannot enjoy a healthy life. And this is not only depending on the country where you live, on your economic status. And we need to provide interventions that are really fitting to protect each and every individual. And this is very true for immunization. I think about my parents. My dad is now traveling around Vietnam somewhere, enjoying this part of his life. My mom is at home because her healthy condition does not allow her to do this travel. Same age, almost 80 years old, same economic status. They are living in a country that is well developed, Italy, but still see the difference. And we are in the very similar group of the older adult population. And last but not least, the equity gap, as we have seen up to now, is highly alarming. And we need to be very careful when we speak about vulnerable population as the older adult population, and to be very conscious when we define the preventative approaches to make sure they are as effective as possible. And effective means also cost effective, as you just said. It takes money to make sure to maintain healthy our population. So I would like to highlight a few recommendations that we have developed at the World Federation of Public Health Association about older adult immunization. And of course can be applied to adult immunization in general. The first one is the need to have central government support and funding. In many countries in the world, there is a line for immunization. It's not in every country. But when we have this line, this budget line for immunization is very often over 1 year. This is not effective. We need to get organized in a best way to have a clear knowledge of the need, to be able to have effective negotiation to get the vaccine, and to make sure that we cover what we need. We make in this report an interesting comparison between immunization spending and defense spending. When governments see the interest in spending money, like for defense, they do. They spend a lot of money, and they spend over several years. We are not here to say we should spend more in defense, but that we should apply the same approach, so high amount of money, and very importantly, over several years for prevention, and immunization can be a very good example because we all know that the return on investment on immunization is very high. The second point is communication. We need to make sure, and to make investment for that we communicate properly to older adults about immunization. And again, if you think about the gap within the older adult population that we have in relation to how they approach to communication, we should understand that the means to communicate should be very, very specific. You have a part of the population that is mainly somehow comfortable with social media. And you have a part of the population that will never ever be able to have a social media account and read newspaper, for example. Or that communicating for them means having a trusted person in the community that speak about vaccination and why they should get vaccinated. Could be the pharmacist, could be a social worker that take care of recreational activities. And very importantly, and not much considered as public health workforce, we have the family around the older adults that could and should be a promoter of healthy habits, including vaccination. And that's why I would like to spend a few words about an intergenerational approach to vaccination that is very much related to access. When an older adult person needs to be vaccinated, should go to the specific center that change according to the country. And depending on the healthy condition of the person can go alone, but in many cases should be accompanied by the son, the daughter, that then take hours of the work to bring the person to the vaccination center. And this is the same person that maybe need to be vaccinated, and for sure is the same person that would need to bring the children to be vaccinated. So why not creating a different system, a different narrative about vaccination and considering intergenerational vaccination, where 3 generations can be vaccinated in the same place at the same time. And this will save time of the person that is in charge of the 3 generations, including his or her generation. Money, less hour loss in terms of work, or need to pay someone else to bring the person to be vaccinated. But what is the most important thing for me is trust. Because if my children see that I am vaccinated and the grandma is vaccinated, they will consciously, unconsciously understand that it's something that is good, that their models do. And so we grow up a generation that is keen to trust this type of prevention, but of course it can be applied to every type of prevention that can be intergenerational. And this is where we can really make the difference. There are some countries where this is implemented. In Brazil, for example, we have the cocoon vaccination that has this kind of approach. In Switzerland, pediatricians start to vaccinate also the parents when they bring kids. But it's not a structural approach. If we make it the norm, this can make a difference. And of course, whatever we do in vaccination, to make sure we are doing the good things, also for the intergenerational approach, we need to monitor and evaluate what we get. And this is extremely important, especially in countries where the data collection is a bit more weak, in less developed countries. So what I would like to suggest today, bringing everything together, we need to change the narrative to a preventive health system where we offer the best approach to all the generation, with a special focus to the most vulnerable. We are very keen to protect our kids. They are cute, they are nice. But we see that when they grow up, and I still stick to vaccination, but it's just as an example, they may become more hesitant. They may have other priorities, other needs. And so the vaccination approach became weak, and we see a reduction in vaccination of the adult generation that got even worse with the older adult generation when access, mobility, other comorbidities would make an important limiting step to the approach. So we really need to think out of the box and find ways to have this more efficient approach to vaccination, and also to consider that the public health workforce we should have on board is much broader than what we have now. We have a shortage of public health workforce compared to the demand, but we need to have more public health workforce on board. And the message is family, parents, teachers, but also journalists. I mean, think any type of influencer within the family, within the community of globally, should be made on our side. We need to make them understanding the role, the impact, and the responsibility they have to protect all our generation. Thank you very much.
Thank you so much. Next up, we have Andrew Moose, who is the head of Health and Wellness. He is presenting on behalf of Dr. Shaim Bashin, the head of Centre for Health and Healthcare and member of the Executive Committee for the World Economic Forum. Thank you.
On behalf of the World Economic Forum, I want to thank the International Longevity Center for the opportunity to come here today and speak to you about how we and our collective members are thinking about the topic of longevity and what exactly this index provides in terms of an evidence base to help build strategies around to promote healthy aging and preventative health across the lifespan. At the World Economic Forum, this is an organization that's been around for over 50 years, headquartered here in Geneva, Switzerland, with a focus on improving the state of the world. A lot of the way that we do that is to convene global leaders in both the public and private sector and really focus on how do we collectively share intelligence to better understand an issue or a challenge, and then work together to take a step back and hopefully see what collective mindset shift might be needed to look at an issue differently. I think in particular with aging and longevity, we've heard earlier today from Dr. Azzopardi Muscat the importance of creating a positive narrative around longevity. I think so much there is just the natural tendency to want to see this as a negative topic or something that is to be avoided or a draw on the economy. I think the evidence base that we've seen is actually quite different. There's a different story here. According recently, some recent research from McKinsey Health Institute says that the global economy could see a lift of between 2 to 15% in global GDP by engaging the workforce for a longer period of time over that span. And so I think that narrative is getting lost in a lot of preconceived notions about longevity and what that means in terms of economies and also organizations within the private sector. And so I think at the forum, there's a couple of things that we've been doing to really work together to establish a common framework, a common language to really drive this collaboration, and research like the Aging Prevention Index really provide that evidence base that's critical to mobilizing together to really build communities and understand frameworks and strategies that we can collectively unify around and then direct impact and investment towards those outcomes. At this past year's annual meeting, our Center for Financial and Monetary Systems, I'm joined here today by my colleague Holly Naziri, who led that work. We released a report around the longevity economy principles. So really taking a deep dive into what are those principles that are critical to understanding and driving positive financial health. And so there were 6 principles that were really laid out there in terms of financial resilience, access to education, healthy aging, really looking at strengthening jobs and skills, also looking at the critical element of social connection and purpose as we age, and also to focus on inequities across gender, race, and class, which we know are quite evident. For example, women typically have about 40% less income than men in retirement, and it's important that we design systems that take these inequalities into account from the very outset. And so a lot of what we're focusing on now is looking at how do we move from this reactive strategy to a focus on prevention. That's always a difficult argument to make from an economic standpoint, especially in systems that are dominated by capitalism and private sector tendencies toward the short term. And so a lot of what we're trying to do is really leverage the evidence base that this index can provide. We were at a discussion earlier today, and one of the leaders that we were working with was talking to his daughter, and she was giving him her recommendations about how to drive global change. And she said there's really 3 things. You need intelligence, which I think the Aging and Prevention Index helps provide. You need a willingness to think differently about an issue and how you're going to address that. And then you need collaboration to really come together, meaningfully mobilize in an effective and practical way, and really drive change. And so at the forum right now, we're looking at this across a multiplicity of aspects, as I mentioned, focusing on financial security for healthy aging, but also starting to look at that health-wealth nexus. How is it that your particular lifestyle and choices from your health are going to affect you as you age? What's your health prognosis? What are the financial assets that you'll need to cover that? I think having that communication much earlier in life so that people understand the choices that they make have this long-term implication. So I think the focus on all spans of life and communication is really critical, and not to see this as the 65 and older, that's the audience that you're directing information towards, but really starting to look much more dynamically that, as you mentioned, people age with different capabilities, and so the need to create more dynamism in terms of just how corporate leaders perceive the population worlds and the people that they serve are critical. And so we're also looking from a health aspect. So we're looking at healthy workforces. How do we work directly with employers to look at holistic health that spans mental, physical, financial, as I mentioned, but also social, emotional, and that sense of connection. And really, a lot of the organizations we're working with are still at the nascent stages of being able to measure actual impact of these types of interventions, but there's a recognition that there's a need to much more holistically embrace prevention strategies, but they're hard to fund. And that's one of the challenges, and so building that business case is a major focus to increase the sophistication in how we measure and gather evidence, but also to identify which interventions are actually working, and then how do you fund that. That takes a near-term ROI case on things like lost productivity and absenteeism, but then it also takes a longer-term view and the importance of why you need to make these investments in terms of creating a societal future that's a positive one, and taking into account the demographics that have been highlighted here that create a start case. We're also looking at bridging health inequity, and as I mentioned, we have a new alliance that we launched this year focused on women's health, so that's another dimension that we're taking in. I think we also see an opportunity that climate and health is increasingly a topic that's rising on the agenda. I think that presents an opportunity to really bring more attention to the issue of aging and also preventative health from the standpoint of understanding what are the implications as you age, and in which parts of the world are you likely to see climate vulnerabilities, and to use that as another context to engage leaders where they are, where that's a focal area and perhaps there isn't as enough attention on longevity and preventative health as we age. So that's just another way that we're trying to craft narratives and really continue to drive that mindset shift towards positivity, towards engagement, and towards longer-term planning in this space. And so we look forward to hopefully continuing to leverage this evidence base that's been presented here today in our narratives as we move toward future communications with our communities, and also to work with all of you here. So I appreciate the opportunity to come and speak to you today.
Thank you, Andy. I'd now like to introduce our keynote speaker, Professor Orazio Schillaci, the Minister for Health, the Italian Minister for Health, I should say. Welcome.
Thanks, Excellencies, distinguished guests. In our nation, the current epidemiological situation shows a significant aging of the population, a high prevalence of non-communicable chronic diseases, and an increase in health risks linked to environment factors. We are convinced that healthy aging is one of the most pressing health emergencies and a key component of health promotion and disease prevention policies. We are particularly keen on healthy nutrition as a key pillar of this approach. In this perspective, healthy and safe nutrition, in association with sustainable lifestyles, play a key role in influencing people's life expectancy and the quality of the final part of life. For this reason, Italy has financed important projects in the nutritional field in the most recent years, promoting the concept of conscious, healthy, and sustainable diets, especially among the younger generation. It's essential to strengthen health promotion to ensure an independent and active life well into old age, transforming the challenge of active aging into an opportunity. Improving people's quality of life promotes self-sufficiency in old age as well as productivity in working age, and it helps to reduce costs for the community and to maintain the sustainability of health and social systems. The pandemic has also strongly underlined the importance of promoting and ensuring healthy and active aging. Innovative approaches, such as those offered by telemedicine and new technologies, are very important for reaching out to older people. To ensure effective home care, the digital literacy of seniors needs to be improved so that they can use mobile apps and other devices to receive information and communicate remotely with relatives and health and social workers. Older people also need accurate information on how and stay healthy in a pandemic and what to do if they get sick. In order to assure the efficiency of the public health system, we believe that it is important to guarantee the retention and turnover of health working force. Italy is reorganizing community-based healthcare delivery through a new healthcare service management requiring multi-professional teams made up by general practitioners, nurses, specialists, doctors, and other health and social professionals adopting a proactive approach towards the patient. Closely related to healthy and active aging is the idea of age-friendly community, where attention is paid to the physical and the social environment and to those factors that can facilitate or hinder the possibility for the elderly to age actively. Promotion of mental health care strategies must be considered a priority and should be implemented through the development of synergic actions aimed at reducing the fragmentation in service delivery and promoting evidence-based strategies to raise positive responses as resilience, self-esteem, and self-efficacy. The National Prevention Plan 2020-2025 adopted in Italy also outlines a renewed commitment to health promotion and disease prevention throughout life. It aims at facilitating senior citizens to remain self-reliant by promoting productivity in working age as a result of harmonious and sustainable development of the human being, of nature, and of the environment, One Health. At the same time, the prevention plan is meant to address all the socio-cultural, environment, relational, and emotional determinants that influence health through a shared and participatory multi-stakeholder planning by actively involving communities in the decision-making process. The National Oncologic Plan adopted last year is aimed at improving the overall path of fight against cancer. The National Oncologic Plan underlines the priority of adequate care and assistance for the elderly with cancer. Age is the most important risk factor for developing a large number of cancer. As life expectancy increases, the number of new cancer diagnoses will increase. This implies the need to address cancer care in a complex population affected by different comorbidities and disabilities. It's essential to keep in mind life expectancy when planning the diagnostic therapeutic path. It is evident that in this demographic and epidemiological context, the care burden for healthcare facilities is rapidly increasing, also by changing the characteristics of the demand. A transversal oncogeriatric interdisciplinary approach with the involvement of the general practitioner is necessary to guarantee integrated assistance capable of acting on the disease, keeping comorbidity factors and functional relapses under control. A global management of the elderly cancer patient through a multidisciplinary and multidimensional approach is also necessary to provide a specific and facilitated diagnostic therapeutic assistance path within the regional oncologic networks, supported by a departmental organization that guarantees the coordination of both hospital and territorial oncological and geriatric care and service. The involvement of the nurse and of the assistant also with the use of IT supports and the training of caregivers are necessary to reduce improper accesses to the hospital and allow better monitoring of treatment toxicities. Furthermore, it's necessary to identify the patients who should be referred for an appropriate multidimensional frailty assessment by the multidisciplinary team, which should be performed through a comprehensive geriatric assessment. With the use of specific screening tools for the early with cancer and with evaluation of the complexity form for psychosocial vulnerability. For patients, the geriatrician of residential and home care facilities can provide this service. The epidemiological impact of neoplasm in the elderly requires the elaboration of integrated training programs both in oncology and geriatrics involving all healthcare professionals. A national surveillance system Silver Steps, Health and Quality of Life in the Third Age, coordinated by the National Institute of Health, ISS, aims to highlight the health conditions and dissemination of prevention action in the over 65s age group. With the help of social and health professionals in collaboration with local social service, it collects information through a questionnaire administered by telephone or face-to-face to describe all the aspects that contribute to the well-being of elderly people, health status, health and social care, identifying and monitoring areas of weakness and risk, and suggesting to decision makers the measures to be implementation to maintain the well-being and independence of the older population. A further innovative aspect concerns the division of the population into 4 subgroups: in good health at low risk of illness, in good health but at risk of illness, at risk of disability, and with disability. For each of them, a description of health conditions, issues, and guidelines for the actions to be taken is provided. Thanks.
Thank you so much. Our next speaker is Professor Iona Kixper, the founder and chair of the Global Health Centre, the Geneva Graduate Institute, and the co-chair of the World Health Summit Council. Thank you.
Good afternoon, it's Ilona Kickbush. It's a difficult name, I know. So I'm delighted to be able to give some comments on the report that has been introduced to us. And coming from the area of health promotion and the many discussions around the determinants of health, I'm of course very happy that the report tries to integrate next to health many of these other determinants and components, the economic, the environmental, and in particular the issue of happiness, which we see is more and more important. But at least from the materials that I got, I was a little bit disconcerted because I asked myself, who is this we? You say we this, we that, we the other. And actually, as we know in our societies and as we know from the impact of COVID-19, the we consists of men and of women. And women age differently than men. Women live differently in societies. And I think that also in relation to health services, to care, women play special roles. And this, interacts in a whole variety of ways that I would strongly recommend that the next round of the ILC work takes into account. So I miss the gender specificity. Because also then one can make some interesting correlations also with the determinants and those other factors. And I'm thinking of some work also done by the WEF. On the one hand, the World Happiness Report, and on the other hand, the Global Gender Gap Report. And it actually turns out that many of the world's happiest countries are also the countries that are best for women. And I'm sure we'll hear something about that from Sweden afterwards. So I think moving into some of those correlations are actually quite important. And we definitely need to look at how the gender dimensions contribute to the overall well-being of society and how that society contributes to the well-being of men and of women in different ways. And we see that in different societies, sometimes women are the happier people, and in some societies, men are. So it's not just, I'm not trying to give a message, everything is dreadful and dire for women or older women. I mean, I'm an example, it's not so dire. But I'm trying to say we need to differentiate, and we need to think about what that means. And that relates to very important discussions here at the World Health Assembly, also this week, on the economics of health for all, on the well-being economy, and on what has been developed in terms of health promotion here at the WHO headquarters in relation to the well-being society and those dimensions. So I think there's an opportunity here to take the materials from the ILC work and relate it in new ways to this overall work that is going on, and that makes that differentiation and therefore allows us to understand the dynamics that we're concerned with in terms of healthy aging, to take that into account in a better way. So that's the first point I wanted to make. The second point I wanted to make is that there are special burdens on women. There are special burdens in the context of women's livelihoods and lives, and I think COVID-19 has shown us that very, very clearly, how differently this pandemic impacted on men and on women. And we often underestimate how severely women were affected by the economic effect of COVID-19. And we see from data, also partly from WEF and others, that decades, I underline this, decades of progress in employment have been lost for women. And 47 million women have been pushed into poverty during COVID-19. And one of the reasons this is happening is health, because many of these women do not have access to universal health coverage. And therefore, any medical support they needed for themselves or their families in terms of COVID-19 had to be paid out of pocket. And the World Bank figures show us that very clearly. And often, again, they don't interrelate it in terms of, whose money this is. This is not always the man's income. This is not always a family income, because very frequently we have women who are heads of families, who are self-employed. Think of all the women in the marketplaces and with their stalls, and who could not open because of lockdown restrictions. So the whole informal economy is something that we neglect, because 740 million women work in the informal economy. And that informal economy also includes care. Care, informal care, is a very, very serious economic factor. So again, if we look at the data and try and look back at what additional data we have received from around the world in relation to the impact of COVID, you have that reflection on general life expectancy going down, but that's, just the warning signal. Say, hey guys, look carefully, look in a more detailed way what is actually happening. Because also what women experienced during COVID-19, they experienced reduced access to health services. And one of the consequences, for example, you might call this intergenerational, is 7 million unwanted pregnancies worldwide. And possibly it was even more. So you see these interfaces that are absolutely important, because at the same time, because of lack of access to health services, you have data that show you that maternal mortality, and that's also something, that's sort of hidden in those data, increased, depending on countries, between 8 and 39%. So I think, the kind of study that you have done should encourage us to move one step further, to look deeper, and to say, what does that mean? Because also in that context, the amount of unpaid care work that women do anyhow increased significantly. And at the same time, what we saw is that the women who work in the formal healthcare system were burdened disproportionately. And therefore also, the happiness level probably in a whole number of countries, and we have data on that, of female healthcare workers went down significantly. And we have reflections of that. And this is also something that I think all our overviews, it's partly captured in the happiness index, but all our overviews around health need to have a much, much stronger focus on the mental health dimension, on issues of anxiety, on the interface between the physical and the mental health, mental well-being. And then, we sort of get a construct of happiness that takes some of these burdens into account, and some of the burden that you actually experience as an older woman in terms of, a triple burden, I would say, and there's interesting data on this, between sexism and ageism. And we do also have to see how that impacts on how you feel about yourself and how you feel about your health and happiness. So I think it's very important to take into account the issue that was raised around that 20% gap. Because very clearly we have a health systems crisis. Very clearly we cannot maintain our health systems as they function right now unless we invest differently. And we very superficially always say, let's invest in health, and then we mean let's invest in health systems. Then we don't include public health in that investment, and we don't really invest in prevention. And that doesn't always need money, it needs regulation. It needs tobacco regulation, it needs alcohol regulation, it needs all kinds of regulation that we are not really moving forward on to the extent that we should. And we're facing in our societies, but also in rapidly aging societies like China. I was at a meeting that the Chinese colleagues had organized yesterday evening. We're seeing this triple burden of NCDs on the one hand rising, as was rightly indicated by many of the previous speakers, the workforce crises we have, which is a women's crisis. 75% of that workforce are female. They are aging. Some of them don't want to go after COVID-19. They don't want to go into these jobs anymore because they are not attractive. They kill you. So we have a workforce crisis, and then we have an informal work crisis, because many of these women are also confronted with, either sandwich generations. They have their older parents, they have their children, but many older women now, because of the longevity that you've spoken about, have to care for even older parents. So, you have the 60, 70-year-olds taking care of the 80, 90-year-olds. And I think we also have to take this type of intergenerational into account much more. When we talk about intergenerational, we usually think here's these young people and here's these old people. No, our societies are developing in a way that it's a very broad spectrum of generations, 5 even to 6 generations. And they are interacting in new ways with one another. We have to take that into account. And that is a new type of intergenerational integration that has very, very strong gender dimensions that I would urge you to take into account. And that means, addressing a whole range also of these determinants of health that you have so rightly highlighted, but to then also look at, you look at the work span, but quite honestly, the work span in informal work hasn't gone down. So you rightly show that, at least here for the UK, that the happiness score has gone down. I'm sure if you read the COVID-19 reports from the UK and the tragedies that happened in terms of the health system, that will explain, a fair number also if, your female happiness score goes down. And so I think the income issues, of course, reflect themselves in many different ways. But again, COVID-19 has not improved it for women, most definitely not. So this is my plea. It's a very old-fashioned plea, but I think I can allow myself to be old-fashioned and to say, particularly with the discussions going on here at the World Health Assembly, where suddenly words related to gender, where equity issues related to women, where sexual and reproductive rights are supposed to be struck from every single WHO document, I would like to be old-fashioned. And I would like to say that nobody here at this World Health Assembly should move in that direction, and that we need to protect the rights of women in a way that the United Nations has done in the past, and that the kind of work we do in analyses always reflects this very special situation. Thank you very much.
Thank you. And I'll quickly introduce our last speaker of today, Dr. Karen Tegmark-Wissel. Thank you.
Thank you very much. So I'm standing between you and the reception, and I hope some of you at least will listen to a few of my remarks. Thank you very much for inviting me to this important side event. Sweden ranks highly on the Healthy Aging Index, and I will briefly share some of the prioritized approaches applied in Sweden aiming to achieve a healthy aging. In June 2018, the Swedish Parliament adopted a new national public health policy, and the policy focuses on equitable health with an overarching objective to eliminate avoidable health inequalities within one generation, and that is set to 2048. And the work for the Public Health Agency, which I am representing, includes monitoring both health and the social determinants of health according to 8 target areas, and to do so in different socio-economic groups. This in order to be able to direct actions and efforts to the groups in society that have the highest risk of ill health. And the COVID-19 pandemic highlighted the inequalities that we have and the need for long-term health promoting and preventive cross-sectorial public health work. And the 8 target areas that are seen on the picture as the flower-like graph over there, they have a whole of society approach, and they target early life, education, work life, income, housing in neighborhoods, healthy behaviors, participation in society, and an equal and accessible health care. So only one of the 8 goals are actually addressing health care. The others are approaching the whole of society. The Swedish guidelines on physical activity and sedentary behavior is part of a larger effort with the aim and purpose to raise awareness of the importance of physical activity and sedentary behavior for a healthy aging. and it is set to identify and promote limiting factors linked to physical activity in different population groups, and strengthening the implementation of the guideline through examples of measures and interventions that really promotes physical activity and reduce the sedentary behavior. It is also aiming to contribute to a common approach within and between different sectors. And the target groups for the guidelines are the decision makers at national, regional, and municipal level, but also the civil society and actors in the public, whether they are private or idea-based sectors. And the objectives are ranging from the children up until the elderly to give the opportunity to have safe and equal opportunities to participate in a variety of physical activities that are fun, suitable, and adapted based on age and functional ability. Another action that has been taken by the government is the proposal of a new 10-year strategy on mental health and suicide prevention. And this strategy also has a comprehensive approach. For one, to combat stigma and discrimination for those that have mental illness, but also to highlight societal inclusion. Being part of a social community and feeling a sense of belonging with a trust in other people is one important measure. And linked to this strategy that the government will present in just a few weeks are several different initiatives, and will be directed to the whole of society. And this strategy will in particular take into account the elderly's own perspective, and also take into account in the follow-up the elderly to be allowed to speak and describe their life situation from their own perspective. In addition to these two initiatives that are fairly new, there are several other areas that we need to address, especially in the elderly group. Although self-reported mental distress in Sweden is highest among the youngest age groups, which is not very reassuring, the rate is also high among women 85 years and older, which you see in the left figure. Men in all ages report mental health issues to a lesser extent than women, but as you can see in the right figure, men has twice as high suicide rates compared to women, and the highest rate is found among men 85 years and older. Another area of improvement is social participation, and the Swedish government has decided to put forward a national strategy to reduce loneliness that will be supported by a comprehensive governmental program to combat loneliness. And several initiatives are financed by the government on regional, municipal, and civil society level in order to address this issue. And the proposal of a national strategy will be presented in February 2025, which again the Public Health Agency is responsible for putting forward. Here we see the figures of single households and perceived loneliness in Sweden. To the left, you can see that 41% of all households in Sweden consists of only one person, and as you can see, the rate increases by age. Thus, the highest rate is found among the oldest age group, where 60 to 80% of the households consists of only one person. Living alone is not the same as feeling lonely, but we know that there is a significant correlation. And to the right, you can see perceived loneliness. 23% of the Swedish population report milder form of loneliness, and the rates are highest among the youngest and the oldest adults. The differences between the sexes is small, except for in the older ages, where more women than men report loneliness. With an aging population and citizen-centered and integrated care with an emphasis on primary care is of high priority in Sweden, and has been mentioned by many, we need to prepare for the forthcoming years with a population that become older. And the objectives with the primary care reform is to increase the involvement of the citizen in his or her health and health care, and also increase the accessibility to healthcare and continuity in the contacts with healthcare staff members. For elderly people with multiple health problems, it is of utmost importance that healthcare services and social services is well coordinated, and that is something we really see is striking when it comes to the vaccination programs. The transition that has been going on for some years has special focus on providing healthcare services at outpatient services when it is most favorable, where it is most favorable, and when for the inhabitants. And we have an ongoing change towards more advanced healthcare services in people's regular homes. Home-based healthcare service is more and more accessible due to the technical and medical improvements. And this includes also an increased focus on health promotion and prevention. Transition towards high-quality, citizen-centered and integrated care aligns with the World Health Organization's goal of achieving universal health coverage worldwide. So where is the computer? There it is. So coming back to the Health Aging and Preventing Index, as was mentioned, Sweden ranked number 3, even though we see several areas that we really need to improve. And life expectancy in Sweden has in generally increased by approximately 2 years during the past 15 years, and as is seen on this picture, half a year during the period 2019 to 2022. Even though Sweden, like the rest of Europe, had great challenges during the pandemic, but we had a very good vaccine uptake, and we were in our approach really trying to address the needs of the entire population from a comprehensive approach, addressing the 8 different target areas of our national public health policy. However, the increase in life expectancy is not true for everyone in Sweden. Like the gap increase among the countries participating in the Healthy Aging Index, the gaps are also increasing between different socioeconomic groups in Sweden. Although the proportion of the population belonging to the group that has the highest education, grade 9, is decreasing, it's only 10% of the population right now, it is still also increasing the gap between this group with the lowest education level, and they are lagging behind. And we see for women it is even decreasing in life expectancy among those that has the lowest education. Sorry, I'm not quite finished. When it comes to the health span, it is also increasing according to this index. And this has made the government put forward new recommended ages for retirement, and they have been decided, and it is now 69 years for those that are born 1981 and later. But many people work even for longer periods. We have a decrease in our environmental performance, and it is most likely influenced by some of the changes in the strategies that the government has put forward, moving from a short-term perspective to a more long-term achievements. And when it comes to happiness, yes, loneliness is a challenge in Sweden, like in many countries, that we believe affect the happiness index. But we see that loneliness is also reported among our young citizens. And we see that it is affected of factors such as the climate crises, the war in Europe, and also the use of digital screens. So in just a few months, we will put forward suggested regulations on how young children will use digital screens, not affecting the elderly, but affecting some of the indexes. But on the other hand, we rank high also in happiness, and in the UN World Happiness Report, Sweden ranks 4th in the world. So even though we have a lot of areas to improve, to work on, we still have a fairly good outcome when it comes to these indexes. So thank you very much for staying for the presentation.
Thank you so much. So that concludes our formal keynote speakers. I'm very, very conscious of time, but I know some people online have some questions for our panellists and some people in the room. So I'd like to invite our speakers up to the front, and we're going to take a maximum of 3 questions, and then we can get you all off to lunch. So I'd like to invite our panellists to the front who are able to stay with us. Well, no? Okay, no worries. I think we might draw it to a close there. And thank you everyone for joining us. Just 2 more things before we leave. If you enjoyed today, we've got another project running at the moment, which is our Going for Gold project, where we are measuring if your country was to compete at the Olympics in regards to healthy ageing, how would it compete? You're all welcome to join us in Paris, on the 16th of July. We would love to see you there. I'd love to thank our keynote speakers today, and thank again our sponsors for this event, and we hope you can all have some lunch downstairs. Thank you so much for coming.